Welcome back. We've covered a lot of ground together. Things like how we eat, how we move, how we support our metabolism with targeted lab work and medication. Now we arrive at factor 4. And in many ways, this is a very personal one. We're talking about hormones, not in a vague catch-all sense, but in a precise, clinically meaningful way. The hormones that govern your body composition, your energy, your mood, your libido, and yes, your ability to lose weight and keep it off. That's what we're going to focus on in today's video. Here's the principle that guides everything in this 5-factor program, and especially this factor number 4. We do not treat numbers. We treat people. Your labs tell us a story, but you tell us the rest of the story. Symptoms matter. Quality of life matters. Our goal is not to reach a target on the reference range. It's to help you feel great and function well, the way you deserve. Let's talk about what we measure and why when it comes to hormones. Before we talk about treatment, let's talk about assessment. When we evaluate your hormonal landscape, we look at carefully selected panel of markers. The first one, fasting insulin. Even if your glucose is normal, elevated insulin tells us your body is working too hard to maintain a metabolic balance. High insulin is one of the most powerful drivers of fat storage that we know of. The next thing we look at is morning cortisol. Cortisol follows an up and down diurnal rhythm throughout the day, peaking in the early morning. We measure it then to get a meaningful baseline of your cortisol. Chronically elevated cortisol promotes abdominal fat deposition, muscle loss, and insulin resistance. If it's too low, your energy and metabolism suffer in a completely different way. Next, we look at your thyroid function, and we use TSH, thyroid stimulating hormone. TSH is secreted from the pituitary gland of the brain and gives us a window into your thyroid's function. The thyroid is a metabolic thermostat for your body. When it's sluggish, everything slows down. Weight loss becomes an uphill battle. We also look at FSH, or follicle stimulating hormone, also from the pituitary gland. This helps us understand where a woman is in her reproductive life cycle. Rising FSH is the hallmark of perimenopause. In men, it can help assess testicular function. Then we look at testosterone, and we check this in both men and women. This is often overlooked in women, and testosterone plays a vital role in lean muscle maintenance, energy, sex drive, and metabolic rate. In men, declining testosterone is one of the most common and underappreciated drivers of middle-age weight gain. A lot of men get that central belly. We look at estradiol. It's the primary active estrogen, and declining estradiol levels in women triggers a cascade of metabolic changes, including increased visceral fat, insulin resistance, and the loss of lean mass. We monitor it carefully in both perimenopause and postmenopause, and in men on testosterone therapy. We'll talk about this later. We look at progesterone. In women, we'll add progesterone. It balances estrogen, promotes better sleep, has a calming effect on the nervous system, and plays an important role in maintaining healthy body composition, particularly in what we call the luteal phase of the woman's monthly cycle and throughout the menopausal transition. Very important hormones to look at. Now that we know what hormones we're going to look at, let's first look at our women patients and their hormones across the lifespan. So the next bit of this is going to be about women. For women, the hormonal conversation is kind of a layered thing, and it changes dramatically across their lifetime. There are really 3 windows in a woman's life where hormonal shifts most commonly intersect with weight gain. And the first one of these is menarche, which is the onset of menstruation, somewhere around 11 to 14. The hormone shifts that accompany puberty bring rising estrogen and progesterone, changes in insulin sensitivity, and a natural redistribution of body fat more toward the hips and thighs. For some young women, these changes also bring the emergence of insulin resistance, disordered eating patterns, or what we call the early signs of polycystic ovarian syndrome, or PCOS, which we'll discuss in more detail shortly. Symptoms to watch for in this phase are things like irregular cycles, acne, hair thinning, and unexplained weight gain despite normal eating. These are not growing pains in young girls. They're signals worth evaluating. The next window we look at is the perinatal and postnatal period of a woman's life. And this is the second window where we see a lot of shifting hormones. Pregnancy and the postpartum period creates profound hormonal changes that could dramatically affect a woman's body weight and body shape. Progesterone rises sharply during this period. Insulin resistance increases physiologically, and the postpartum drop in estrogen and progesterone can be swift and very destabilizing in many women. Many women find that weight gain during pregnancy does not come off as expected after delivery. This can also be compounded by things like sleep deprivation with that new baby, stress, breastfeeding hormones, and the early signs of postpartum thyroiditis. It's a condition where the immune system temporarily disrupts our thyroid function. So this period around giving birth is a struggling period for women's weight. Symptoms in this phase are persistent weight retention and water retention, profound fatigue beyond what would be expected from new parenthood, mood changes, low libido, hair loss, all of them very worth investigating rather than accepting them as it's a normal part of pregnancy and childbirth. The third and most impactful window for women from a weight management standpoint is the menopausal transition. Perimenopause can begin a decade, 10 years before the final menstrual period occurs. Estradiol becomes erratic, progesterone declines, testosterone falls, and the body's relationship with insulin fundamentally will shift during this time period. Symptoms of estrogen deficiency will include things like hot flashes, night sweats, sleep disruption, vaginal dryness, mood changes, cognitive fog, what many women call brain fog. But equally important from our perspective are increased visceral abdominal fat, loss of lean muscle mass, elevated fasting sugars, and accelerating cardiovascular risk. So the symptoms of low progesterone include things like poor sleep quality, anxiety, irregular and heavy periods in the perimenopausal period, water retention, and an overall feeling of being kind of on edge. Symptoms of low testosterone in women are fatigue, low motivation, reduced sex drive, difficulty maintaining muscle despite exercise, and a flattening of overall vitality. You just lose that energy. Now, let's explore PCOS like I talked about just a bit more. It deserves special attention. It's one of the most common hormonal disorders in reproductive age women, and it sits kind of at the intersection of hormones, metabolism, and weight. Women with PCOS often present to us with elevated androgens or male hormones, including testosterone. Insulin resistance occurs, irregular cycles, and difficulty losing weight that feels very disproportionate to their caloric intake. It's also a major factor in the inability to conceive. Now, this is not a willpower problem. It's a metabolic and endocrine disorder. And you see it in a lot of teenage girls. And it responds beautifully to a comprehensive approach. The treatment must address insulin resistance, try to support ovarian function, and when appropriate, gentle modulation of the hormonal environment. Proper treatment can correct many of the symptoms and problems and can assist with restoring improvement in the chances for conception. So this is a problem. Look at the teenage and young women to see if they might have that. Women have a complex hormonal system. It deserves careful evaluation and treatment when that treatment is indicated. Now, I'm going to shift my attention to men and what we call the andropause, which is really just a slow decline over life of testosterone. The male hormone story, much different than that of women, maybe a little simpler, but no less important. Testosterone doesn't fall off a cliff the way estrogen does in women at menopause. Instead, it declines gradually, roughly 1 to 2% per year, beginning somewhere in the mid-30s. Now, this slow decline often goes unnoticed for many years, and men, they tend to just adapt to it. They attribute fatigue to, I got work stress, or they accept expanding waistlines as inevitable, the dad bod. They push themselves at the gym, but recovery just takes longer and longer. They lose their edge, their drive, their clarity, their confidence, and they just call it aging. Even many doctors tell men, you're just getting older. Well, that's sad. I'd like to challenge that framing that we put on these middle-aged men. Symptoms of low testosterone in men are central weight gain around the belly, particularly the abdominal fat, loss of lean muscle mass, fatigue, reduced sex drive or libido, erectile dysfunction, mood changes, which include irritability and low-grade depression, reduced motivation, cognitive slowing, and difficulty losing weight, even with a disciplined diet and exercise. Critically, low testosterone and increased body fat create this vicious cycle. Fat tissue, especially visceral fat, contains an enzyme called aromatase, which actually converts testosterone over into estradiol. The more abdominal fat a man carries, the more testosterone he converts to estrogen, the lower his testosterone falls, and this cycle continues. Breaking this cycle requires addressing both the hormone and the metabolic environment simultaneously, which is exactly what my 5-factor approach to weight control does. So, working on the 5 factors is essential. Now that we've covered the key hormones we evaluate and optimize, let's move on to the treatment philosophy for hormones. Before we talk about specific treatments, let me be clear about my approach. We do not prescribe hormones because your number is below a reference range. We prescribe hormones or decide not to based on the full picture: your symptoms, your history, your goals, your risk factors, your labs, and even your preferences. Hormone optimization is a full conversation, not a protocol. I see many men's clinics and online men's health plans give lip service to the whole patient and move quickly to, here's a prescription, most likely to create volume and enhance the bottom line. I see many men in my clinic who are taking too little testosterone, too much testosterone, too many additional medication or add-on therapies for side effects they don't even have, and who just don't feel good with their treatment from these men's testosterone mills. Know that there are many physicians who are very good at treating this and will monitor and adjust therapy to optimize total hormonal health and not just shoot for a good number on a lab report or follow some corporate treatment protocol sheet that they've been given by the company that hired them. Once we begin treatment, we monitor very closely. We check levels regularly, typically every 6 to 8 weeks initially, until we reach what we call the optimal zone. This optimal zone is a place where your symptoms have resolved, your metabolic markers are moving in the right direction, and you feel like yourself again. And that's different for every single patient. Once we're there, we move to a 6-month monitoring interval so we can fine-tune and ensure long-term safety and success with the program. Let's first look at hormonal therapy in women, a little more complex than men. Estradiol replacement is kind of the cornerstone of menopausal hormonal therapy. We have several different delivery options, and the right choice depends on your preference, your skin, your lifestyle, and the dose we're targeting to achieve a level. There are transdermal patches which are applied to the skin twice weekly. They deliver a nice, consistent, predictable level of estradiol with excellent absorption. They also bypass the liver's first pass metabolism we see with oral ingestion. When you eat a medication, it has to go through the liver for processing, and there's an advantage to this. We can also use transdermal gels and creams, which are applied daily to the inner arm, inner thigh, or abdomen. Flexible dosing and fine-tuning are a little easier with this type of delivery system. It does also require a little attention to avoid transferring the medicine from the patient to their partner or children. So the cream or gel must be dry before contacting others. Applying the hormones to the inner thigh usually can eliminate this risk. So there are risks, and you got to be careful with that. Estradiol can also be administered vaginally. For women whose primary symptoms are vaginal atrophy or shrinkage and urinary changes, this is a great approach. Minimal systemic absorption occurs at low levels or doses, making it a reasonable option even for women who cannot or prefer not to use a more systemic type therapy like we talked about a little earlier. Small compounded subcutaneous pellets can also be implanted under the skin in the hip or buttocks area. They dissolve slowly over 3 to 6 months to deliver a steady physiologic level of estradiol. With that, there's no daily applications, remember, and this is an excellent choice for women who want consistent levels without the variability of other delivery methods. You just come in the office, we put the pellets in every 3, 4 to 6 months. Progesterone placement is essential and must be done for women with a uterus who are taking estrogen. I also use it in women without a uterus as it is an important hormone to aid in sleep, keeping our nervous system calm, and balancing the effects of estradiol throughout the body and mind. I prefer bioidentical oral micronized progesterone, which is often taken at bedtime, as it has that mild calming effect, mildly sedating quality that improves sleep. It's very distinct from synthetic progestins used in older formulations and has a much more favorable safety and tolerability profile than the progestins do. So I recommend avoiding progestins like medroxyprogesterone. Progesterone is also available as a topical cream for women who prefer not to take oral medications, though absorption with this can be a little bit more variable, so you have to kind of watch that. Now, let's look at testosterone therapy in women. Yes, testosterone use in women is one of the most evidence-supported yet underutilized interventions in women's hormonal health. Doses are much lower than in men, typically 5 to 15% of the total male dose, but the effect on energy, libido and sex drive, lean muscle, and cognitive clarity can be profound. And women make progesterone throughout their life. We can use topical testosterone cream or gel applied in small amounts to the inner thigh, labia, or forearm. This requires careful dosing to avoid any what we call supraphysiologic levels, but experienced physicians should have no problems with this. This way we can avoid male side effects. We can also use the subcutaneous pellets again here, and this is becoming popular for women because they eliminate that daily application and provide stable levels over 3 to 4 month period. So again, just come in the office, we put the pellets in. I become a fan of this once weekly injection of testosterone in women with low doses and have found very steady levels of testosterone with monitoring of these patients. So it's a simple weekly injection, usually in the lateral thigh or buttocks. We monitor testosterone and estradiol closely in women on any androgen therapy to prevent inadvertent excess, which causes the male patterns such as acne, hair thinning, very rarely voice changes, and that only occurs at extremely high doses. Now, I'd like to shift gears and cover testosterone therapy in men. For men with symptoms of low testosterone, we call hypogonadism, replacing this hormone can be genuinely life-changing. Let me walk you through the options that a man has when it comes to low testosterone. I use intramuscular injections about 95% of my male patients who are on testosterone therapy. This injection is given weekly to ensure stable levels. The testosterone is in an oil-based fluid for injection, and it was originally recommended once a month, but injection at once a month, the levels would rise and fall in a bell curve over the month. Giving a weekly injection of the monthly medication provides a really nice steady level of testosterone, and therefore symptoms don't change or fluctuate. These injections can also be given under the skin, called subcutaneous. For this, a smaller needle can be used. Now, I have never had a man who could not be able to learn and perform self-injection with proper training sessions in my office. We can, however, also use transdermal gels and creams. They can be applied daily to the shoulders, upper arms, inner thighs, or underarm. It's convenient, non-invasive, easily adjustable. Transfer precaution is essential because you don't want this testosterone getting onto your partner or child. I do find topical testosterone delivery in men may not provide adequate levels, as the skin is much thicker in men than it is in women and more variable depending on a man's work environment. So it's hard sometimes to get these gels or creams to absorb. Each method has its advantages. I always have to discuss with the patient to see what best fits the guy's lifestyle and their therapeutic goals. Side effects can occur with testosterone therapy, and I discuss them before every treatment protocol, and they're addressed if they do occur. The first thing to look out for is what we call erythrocytosis. Testosterone stimulates red blood cell production in the bone marrow. It's a normal physiologic response, and in fact, it's one of the reasons testosterone kind of contributes to higher energy level and better endurance. Now, in rare cases, if production becomes too high, blood might thicken a little and could cause increased clotting risk, though there's been no study to prove that, and in years and years and years of treatment, I have never seen that. We monitor the hematocrit, which is the proportion of red cells in your blood, on a regular schedule. If it rises above a certain threshold, then we adjust the dose of testosterone, which lowers the blood count, or in some rare cases, recommend people go give blood. That's basically simply drawing blood out of the body, and it reduces the level of these excess cells. But that's pretty rare. An important clarification here. The elevated hematocrit we see in testosterone therapy is called benign erythrocytosis. It is not the same as polycythemia rubra vera, which is a bone marrow disorder involving the JAK2 gene mutation that drives uncontrolled red blood cell production independent of hormone stimulation. These are entirely different conditions. Testosterone related to erythrocytosis is dose-dependent and reversible. Polycythemia vera is a separate disease that requires hematologic evaluation and management, usually by a hematologist or oncologist. So we are alert to distinguish between the two and advise our patients to let any doctor that they may see know they are on testosterone therapy to avoid undue concern that this could be polycythemia rubra vera. So just an important thing, some people get that confused. Another side effect related to testosterone treatment is reduced sperm count and fertility in men. This is one of the most important conversations that I have with men who are still in their reproductive age or are considering testosterone therapy. Exogenous or externally administered testosterone tells our pituitary gland to reduce its production of luteinizing hormone and follicle stimulating hormone. So those levels of those hormones go down. These are the hormones that drive testicular testosterone production and critically sperm production. The result here is suppression of sperm production, and it can be significant. Also, as less sperm is produced, the testicles which store sperm will reduce slightly in size. This is not from testicle tissue shrinkage, but from less sperm volume production and storage. So there's less sperm in the warehouse, so the warehouse doesn't have to be as large. For men who have completed their family and are not concerned about fertility, this is not even an issue. So for men who want to preserve fertility, we have some alternatives. We can use human chorionic gonadotropin, or HCG, which mimics luteinizing hormone. And luteinizing hormone directly stimulates testicular function. And that maintains sperm production even while the pituitary is being suppressed. Another option is clomiphene citrate. It's another option that stimulates the body's own hormone production rather than replacing it from the outside. So that could be used instead of testosterone. The truth is that the vast majority of our patients considered for testosterone therapy aren't in their prime reproductive age and are beyond the attempting of having more children. So it rarely is a problem, but we do have that conversation. Another possible issue with testosterone replacement deals with the conversion of testosterone over to estradiol. As testosterone levels rise in men, some of that testosterone is converted to estradiol by, again, that aromatase enzyme, which is particularly found in adipose or fat tissue. Elevated estradiol levels in men can cause things like gynecomastia or breast tissue development, the enlargement of the breast area, fluid retention, and mood changes. So we monitor estradiol in all men on testosterone therapy. If estradiol climbs too high, we may use a low-dose aromatase inhibitor called an anastrozole, for example, which maintains a healthy testosterone to estrogen balance. So the goal here is balance, not the elimination of estradiol. Men do need some estradiol for bone health, cardiovascular protection, and cognitive function. The next possible side effect we deal with is changes to the hair and skin. Both men and women on testosterone therapy may notice increased oiliness of the skin, or in genetically predisposed individuals, acceleration of what we call androgenic hair thinning or some loss of hair. These effects are, again, dose dependent and managed by adjusting the dose rather than abandoning it. Topical treatments of the hair can be used when appropriate, and rarely DHT or dihydrotestosterone, which is a breakdown molecule of testosterone, might be used and is helpful because the DHT is really the culprit in this mild hair loss. When we use testosterone in women, we carefully monitor the levels to ensure they remain in the female physiologic range. Though we may reach the top of that normal range, side effects again are very, very rare. If excess testosterone persists in women, this can cause acne, clitoral sensitivity, hair thinning, and rarely voice changes. These effects are reversible with lowering the dose. We start low, go slow, and check regularly. I'll touch a bit on how we monitor our hormone therapy patients. So first, we get a baseline of labs before we ever initiate hormone therapy, including a complete metabolic panel, lipid panel, CBC, and hormone-specific markers. Then, we do follow-up labs at 6 to 8 weeks after initiating or anytime we adjust treatment. These tests will include a repeat of testosterone and estradiol levels, hematocrit or blood count, and relevant markers. We continue monitoring every 8 weeks until we achieve clinical and biochemical optimization. Well, that's where the symptoms have resolved and the labs are in the range we're looking to achieve, not just the normal range. Now, once we've optimized, monitoring transitions to every 6 months when we assess hormone levels, metabolic markers, symptom review, and we kind of fine-tune the regimen. Annually, we like to do a comprehensive evaluation, including any age-related cancer screenings, bone density assessment where that's indicated, and kind of take a broader view of a patient's overall health trajectory. What's happening with their health overall. Hormone optimization is not a one-time intervention. It's an ongoing relationship with a person's physiology. Our bodies change. Our needs change. We must stay engaged to keep a person and their body operating at their physiologic best. I'm going to finish up this talk now. Hormone optimization is perhaps the most individualized factor in this 5-factor approach to weight loss. There is no universal protocol, no cookie cutter, no dose that works for everybody, no delivery method that suits every lifestyle, and no target level that means the same thing for every patient we see. Getting a thorough evaluation, having an honest conversation, and developing a personalized plan built around who you are and how you feel is a must. So don't settle for some quick online plan to get hormones, as that's a recipe for side effects and possibly feeling worse down the road. And I know it happens every day. Here's the truth. Optimal metabolic health isn't just about a number on a scale. It's about having the energy to show up fully every day in your life. It's about thinking clearly, sleeping deeply, moving through the world with strength and confidence. And hormones are a big part of that story. In my next video, we'll discuss Factor 5, which kind of brings this thing all together. I'll discuss the behavioral and lifestyle habits that support lasting weight loss and lasting change. The best medicine in the world works better when our daily habits reinforce it. Our mind is what directs the rest of us. We can't change our health, and we can't change our weight, and we can't change our lives unless we first change our minds. I'll see you in the next video. I'm Dr. Greg Oliver. Bye for now.